So it's my pleasure to introduce our two speakers tonight. I think first it's going to be Professor Seligman, is that correct?
Yep.
So Jenny is Professor of Gastrointestinal Oncology at the University of Leeds and an honorary consultant medical oncologist. Her research interests are translational clinical trials in colorectal cancer, and she's the chief investigator of the International Foxtrot and platform and the Aerial trial. She's a member of the ESMO GI faculty, ESMO Congress Scientific Committee, and Guidelines Committee. So it's a pleasure to welcome Jenny to present this evening on colorectal cancer. And I'll allow you to
Thank
share your screen now, Jenny.
Right. So, really nice to be here tonight. Thank you for the invitation. I just want to echo what Richard has said about this trying to be as interactive as possible. I don't plan just to read off a slide deck for 30 minutes. To that effect, I've asked Chris to stay online so we can have a bit of a interactive discussion. But that being said, what would be even better is if you ask questions as we went along, queried something, or even if there's something that's not on the talk, we're very happy to take any questions. In terms of how I pitched this, so I realise we have quite a mixed attendees in terms of your experience in treating colorectal cancer. I've tried to be relatively comprehensive here, and we'll touch on some things and not on others in as much detail. So I suppose for some of you, it may be your bread and butter, and for others, hopefully it doesn't go into quite too much detail. So we're trying to get the balance right, but hopefully that's where discussion and questions can come in. So you can see that in the introduction. Metastatic colorectal cancer, probably we could have done a presentation in 10 minutes about 10, 15 years ago, but actually it's been one of the really changing fields, I would say, in the past 5 to 10 years. And we used to be the poor cousin, I would say, of lung cancer, breast cancer, and then melanoma. But actually, I hope by the end of this talk, you will see that colorectal cancer is one of the places to be. It's really interesting, and it's moving really quickly, and it's really exciting to be part of that. So I'll focus on metastatic colorectal cancer then. Chris will go into early. And I think one of the things to think about is how then you can take some lessons from the metastatic setting and think how they could be applied in the locally advanced setting. So this may be very bread and butter, but I think this is always a good place to start. So your first assessment of a metastatic colorectal cancer patient. And of course, there's some things here that are very consistent with any other tumor type in an oncology clinic. But there's also some things that are specific to colorectal cancer. Picking out a couple of them is things like primary tumor location. Is this a right-sided or a left-sided tumor? And we'll go into why this is important. But also the primary tumor status. So this is really important because the bowel is obviously, there's some very important plumbing which is involved. What is the tumor out? Is the tumor in? May the tumor obstruct? Is the tumor stented? Could the tumor obstruct in the future? These are all things that are important to bear in mind for your first assessment. Presence of symptoms, again, is important making first decisions. And the one thing that we're seeing very clearly in gastrointestinal cancer, particularly in colorectal cancer, is a worrying trend of increasing incidence in young patients. Which I think we're seeing a lot of in cancer above the board, but certainly in colorectal cancer. So in terms of younger patients, they have very specific considerations. Chris, Richard, do you want to mention a couple of those that spring to mind with colorectal cancer?
Yeah, so obviously colorectal cancer in the young is emerging as a sort of pandemic at the moment of increasing incidence of patients in younger age groups, and we're starting to understand a little bit more perhaps about what might be causing that. There was a paper out last week about alcohol consumption in relationship with early onset colorectal cancer, but that doesn't seem to be to a similar degree as you see with hepatocellular carcinoma or anything like that. But yeah, these are patients who are generally fit before presentation, and so and obviously have very different thoughts about how they want their treatment to go, perhaps than considerations of young children in the family and so on, that make it very complex in talking to them about decision making going forward?
Yeah, it's very complex, and I suppose the temptation is to push as hard as you can all the time with these patients, and sometimes that can be something that can be quite difficult. They don't seem to have a worse prognosis than other patients, but certainly there's things like RAS mutations appear to be more prevalent, which are associated with poor prognosis. And remember, there's things like stomas, and whilst having a stoma has an impact on a younger patient, this is particularly the case. I have somebody the other day who didn't want to go swimming with their kids anymore, for example. So anyway, lots of things to take into account on first meeting, and of course patient preference is key. So this slide just gives a bit of an overview on some principles in metastatic colorectal cancer, and I think one of the most critical things is that this is one of the tumor types where the multidisciplinary team is critical. So we're very much part of a team looking after these patients, because it's oligometastatic approaches are probably more common than in other cancers, so ablative techniques, surgical resections, and this field is growing more and more, and the surgical fields are growing more and more. We're looking at things like liver transplantations and things like that. So this is only growing. So it's really important to think of multidisciplinary management when we're considering this as a whole, and not just the chemotherapy aspect. So we're going to go through some of these principles here. We'll start with induction strategies. And the current ESMO guidelines were released last year, and actually this diagram is extremely different from the one that had been in the previous guidelines, which were 6 or 7 years old. So as you can see, patients are put into categories depending not just on molecular status, but also frailty, comorbidities, and then this right versus left colon gets into it as well. So it's a good point just to stand back and then just consider genomic markers in metastatic colorectal cancer. And these are just ones with potential existing treatment options. Actually, these are driver mutations, and actually there's many other ways of classifying. There's something called molecular RNA expression patterns, but that hasn't been shown as yet to lead to distinct treatment options. So as you can see, the big ones in colorectal cancer is RAS. So is the tumor RAS mutated or not? And then if they're not RAS or BRAF mutated, they go into their own category, which is RAS-RAF wild type, which has therapeutic implications. We've also got some new kids on the block over the past few years. So HER2 is emerging, BRAF is established, NRAS and mutant KRAS and exons 3 and 4 have also become far more established, I would say, in the past 5 years. So for that reason, it's now not just something that should happen in trial settings. Actually, molecular testing should be done as a standard for any patient with metastatic colorectal cancer. And the ESMO guidelines suggest that at the least KRAS, NRAS, BRAF, and MSI status or mismatch repair status are tested. Of course, with the genomic hubs, there'll be an opportunity actually to get far more detail about your patient, but beyond the driver mutations, it will be difficult to interpret how to use that information, I would suggest, and that will be a topic of interest for the next few years. So very briefly, sidedness of the tumor in the colon. So and again, this is a bit of a blunt tool. So the colon is divided into two at the splenic flexure. So left-sided tumors include rectal tumors, and of course we know there's lots of differences between them. And right-sided tumors are proximal to the splenic flexure, but they are very different. So they've got different embryonic origins. And as you can see, they both have differences in terms of their molecular characteristics, but also in the patient characteristics. And also, really, we often see that right-sided tumors present later because stool, of course, is more liquid as it goes through the right side of the tumor. And we tend to find patients with the right side tend to present with more advanced tumors, as patients with the left-sided tumors often get more symptoms. So again, you can see the left-sided tumors more likely to be RAS wild type, and we've given some of the detail there. So then we start thinking about, so we're going to divide it into the big categories, so RAS wild type, RAS mutant, and right versus left hemicolon, to get to kind of build up that ESMO algorithm. So we find the BRAF mutant group within the RAS wild type population, and they're usually got a right-sided tumour. The MSI high are usually, I would say, more on the right side. And then we have specific RAS mutations. And again, maybe if I do this talk in 5 years, I'll have more to say about that. And HER2, as I'll discuss, is coming soon. So let's firstly look at RAS wild type and BRAF wild type. So this is approximately 40% of the population. And the ESMO guidelines suggests that if they have left-sided colon, they should have anti-EGFR agents. So those are cetuximab and panitumumab. And that was based upon meta-analyses, seeing that in the right side of the tumour, actually, they didn't add anything to chemotherapy. And when we go back to the biology slide, well, that kind of makes sense. There is a caveat to that, of course, and I would urge you all, if you didn't know about the aerial trial, to find out about the aerial trial. So that's selecting patients with right-sided tumours who may still respond to anti-EGFR agents. But that is really a long story for another day. So what ESMO suggests is that if you have a left-sided tumour, you have chemotherapy plus anti-EGFR. And then the next big story in induction chemotherapy is well, how intensive should the chemotherapy be? Particularly when you're thinking of downstaging patients, perhaps for a liver resection. And the Italians have really led the field here, looking at triplet chemotherapy with FOLFOXIRI, and all these trials included bevacizumab versus doublet chemotherapy. And over 5 trials, what they saw very convincingly is that there was both a response rate advantage, a PFS advantage, and an overall survival advantage of giving triplet chemotherapy compared with doublet chemotherapy. So you may think, right, well, who would we give that to? So Chris, I mean, we give quite a bit of triplet chemotherapy, I would say. I always think the toxicity is not too bad if you know how to use it. Sickness is usually a problem. And any thoughts on triplet? Because as I understand, it's not something that's done as much in the UK as I would say Italy.
Yeah, so as you say, then the Italians are they've led the field in this area, so I think they're the most comfortable. They've done the most trials here, so a lot of their centres are used to this and familiar with the combinations. They're even throwing immunotherapy in with triplet chemotherapy now, which shows you their familiarity with it. And they
assure me that it goes dreamingly.
Yes, well, they have completed the Atezo Tribe trial now, which showed that they managed to deliver it safely to a group of people. So I think people are becoming less nervous about this regimen. We're becoming more used to it ourselves with in the Foxtrot 3 trial where it's being used. Clearly, it's something for younger and fitter patients. And then I think with the Italian data, then BRAF mutation status seems to be an important factor here as well.
Yeah, although it's one of those things, BRAF, you need to be a bit careful with BRAF because it's quite a small subgroup to look at. But I agree with you, and I think that's highlighted in the analyses as well. And so then, of course, the Italians are unfazed. Let the triplet study. So actually, should we be giving triplet along with anti-EGFR? So there was a phase 2 trial that suggested that this would be a good idea. And actually, the phase 3 trial said quite equivocally that actually it didn't add anything to doublet plus anti-EGFR. And so where that leaves us, I feel, is that for patients who have got a left-sided tumour, they should have a doublet chemotherapy plus anti-EGFR. And as Chris quite rightly said, in the triplet trials, they looked at the effectiveness of triplet by mutation status, quite clearly helpful within the RAS mutant group, but actually the one group where it was less clear was the BRAF mutant group. So I think really the advice is to continue with doublet plus just doublet chemotherapy in that group. But that's a bit of an area of contention. So this kind of leads us to chemotherapy triplet. And of course, with the guidelines that we include bevacizumab, but this, of course, is not available in the UK within the NHS structure, but all the trials are with bevacizumab. So it's worth just pointing that out. And so for the right side of the colon, we would say the same for induction, but sometimes some people still give doublet plus anti-EGFR, and that is in the guidelines. Probably not something I would do after the new EPOC study showed that could lead to later recurrences. And so I think our usual practice in the UK, particularly if you're wanting to downstage in a fit patient, would be to consider triplet chemotherapy. And certainly we would be very happy if you had any questions about delivering that as we have been doing it for some time, and probably I think more than a lot of other centres have been doing it. There's specific inhibitors that are used. So there's 12C inhibitors, but they remain in phase 2 trials and not quite ready. HER2, however, is coming, as we will discuss, but certainly not in the first line. Within the first line for HER2, there's the Mountaineer trial, Mountaineer 3, which has just started recruiting. So that's looking to move HER2 testing and treatment to the third line compared with chemotherapy alone. But it needs to be borne in mind that these are only 3 to 5% of the population. So what about MSI high patients? So this was a real eureka moment in colorectal cancer. At last, we can join in. We were watching with envy as everybody else was delivering immunotherapy with great results. And everything we tried was a complete bust. And that's until we tried it in a very specific biomarker group, which is the deficient mismatch repair group. And these are a group that have, they're hypermutated, and they're immune hot rather than cold, which most of colorectal cancer is. And the subgroup analysis showed pretty consistently that it was helpful across subgroups, including groups like the BRAF mutant patients and the KRAS mutant patients, and the primary tumor location. The only thing of concern is these, so we're seeing this long-term group that are doing really well. They seem to, if they're doing well at 12 months, they appear to continue doing well. And you see these people every so often coming back to your clinic, and it's a real joy as a colorectal oncologist to see these patients in kind of long-term remission. It's something that we've never really seen before, but there is a note of caution because there are some patients that don't respond. So they've got deficient mismatch repair or MSI high tumors, and yet they very much fall off the perch at the very start. So we don't know how to identify these patients. So PD-1 hasn't been as helpful in colorectal cancer as in other cancers. And so this is ongoing work in progress, I would say. So for these patients, first line should be a checkpoint inhibitor. So just very briefly to touch on ablation strategies. Again, this is done, I would say, more in Europe and the US than it is in the UK. So we don't tend to deliver things like TACE. They're not reimbursed. Whereas most colorectal MDTs are very active in terms of metastectomies, in terms of lung metastectomies, and increasingly things like SABR. But the liver is always been quite important with colorectal because there is a chance of cure with these patients. So the liver surgeons, there's been lots of different ways. There's how much chemo to give first, what procedure to do, can you do chemotherapy plus ablation? And as I said earlier, there, there's a whole field now moving to transplantation. So I would say watch this space. And of course, some patients will have no systemic treatment and move straight to ablation. So certainly for limited metastases, this is often the pathway. How to manage limited metastases. This is often a bit of art as well as a science. You've got prognostic clinical and biological factors. We don't really have predictive biological factors more than prognostic, but we have patients who can be easily resectable, more difficult to resect. And these are all judgments that the MDT has to make. And quite often you can see, every so often you get a patient that you think will be unresectable and they have an excellent response to chemotherapy, and the liver surgeons will take them to surgery. But just bear in mind that quite often those patients will come back 3 to 6 months later with further metastases. So it does need quite a balanced MDT, I would say. So post-induction surgery, so they've completed induction chemotherapy. What next? So induction chemotherapy is usually 8 to 16 weeks. And one thing that we do, I would say again, more in colorectal cancer than in others, is maintenance treatment. And that's quite controversial, because what does a patient want? Some patients want the best possible treatment. Some want just to spend time with their family, and some really are looking to you to tell you. So I'm not going to go through all these trials, but it's a controversial area. And I think if you move between centres as a trainee, you may see different people doing different things. It made the Focus 4 trial ran in the maintenance setting, and we saw very clearly there's quite different practice, and all the practice actually can be justified by the evidence. I mean, Chris, we have any feelings on maintenance as we quickly touch over that?
Yeah, patient preference, as you say, really does factor into it quite significantly. There's a lot of patients who get very nervous about having treatment breaks and really don't want to be on a treatment break. And there's evidence that from Focus 4 that single agent treatment can be useful, but it's not the be all and end all. And similarly, so you should be able to reassure patients who do want a treatment break that they're not putting themselves in jeopardy necessarily. But certainly continuing with full whack chemotherapy, I don't think is anyone would be proposing that these days after the induction period, and the Italian data is.
Yeah, I mean, it's really difficult. I mean, the whole maintenance field came about because of the neuropathy associated with oxaliplatin. So that's why it really became into the forefront of colorectal cancer management, because we were just seeing all these people with just terribly debilitating neuropathy. And so the question was, do you completely stop the chemotherapy, or do you just drop the oxaliplatin? And so actually with irinotecan, we don't actually have any data to say what's the best thing to do, because most of the maintenance trials have been done with oxaliplatin. So actually some in the guidelines, technically, it's a bit woolly and on the fence about what to do with irinotecan. Personally, I would either drop to capecitabine or give a complete treatment break. But as you say, there's some patients that prefer to continue. But I think it's useful to just be aware of the what's important with maintenance chemotherapy. With induction, you're trying to get response. You're trying to, as well as improve progression-free survival but symptoms as well. When you get into the maintenance setting, actually, if you're telling someone, well, we're trying to balance you going on holiday and having a break versus you continuing to come in, actually survival really needs to be the endpoint, and none of the trials have overall survival as the primary endpoint. And actually the meta-analyses have shown absolutely no difference between maintenance and treatment breaks in overall survival. But of course, as we see from Focus 4, there's a very clear progression-free survival benefit from continuing on maintenance. So, but again, we see see nothing on overall survival. So Richard Adams has and again has done overall survival, has done meta-analyses on very large number of patients, including patients from COIN as well. And whilst you see a progression-free survival in continuing chemotherapy, less so for overall survival. So it's a tricky area, even more tricky with RAS wild type patients. So because they have to have infusional 5-FU, they can't have capecitabine alongside their anti-EGFR agent. So if you're continuing with maintenance, they have to continue with infusional, which either means continuing with a PICC line or maybe increasing uses of ports perhaps. But what we clearly saw is that just having 5-FU alone is inferior from 5-FU plus panitumumab. So the best practice, according to the evidence in these patients, is to drop the one of the backbone chemotherapies and continue the 5-FU plus the anti-EGFR. From another trial, we saw giving the anti-EGFR alone was not helpful. So there's lots of different caveats, and I'm not going to go through this in great detail with you, but as you can see, there's lots of different routes that a patient could go down within the guidelines. So I'll just spend 5 minutes at the end talking about re-challenge. And actually, this is really one of the exciting areas in colorectal cancer. And there's new drugs coming through that I think will actually be available to us in the clinic quite soon, and different strategies. But remember, it's very important when you're going back, think about how well your first-line chemotherapy worked, and also think about your first-line toxicity. And one thing that's quite difficult, particularly if you've got maintenance, is, well, what's second line and what's reintroduction? And some of these factors will come into play. Usually, a note of hazard, if your patient has progressed on an anti-EGFR agent in the maintenance setting, very clear data, stop the anti-EGFR, don't just add another chemotherapy, very clear data, biologically it doesn't make sense. These people will have developed a RAS mutation, please stop their anti-EGFR. That's the main caveat, I think, for this. And I think just also bear in mind that it's a law of diminishing returns in terms of the fall off between first line, second line, third line, and fourth line in terms of the number of patients that receive treatment, but also the probability of clinical benefit. So just bear this in mind. And I think this is, again, a really good argument for giving the most effective first line that you have, be it with FOLFOXIRI or using the anti-EGFR well, or moving some of these targeted treatments to the first line. What we know is patients are more likely to ever get the treatment if they get it sooner rather than later. Now, this is a complicated slide suggesting what you do between first line and second line. With chemotherapy, I wish it was something more scientific than this. But usually, if you give oxaliplatin base, change to FOLFIRI and the other way around. But there's some interesting groups. So BRAF mutated patients, you've got the option of giving BRAF targeted treatments in the second line and beyond. But again, I would urge people to give them in the second line. And again, we have a very complicated schema here, but really the two biggest subgroups that are important are the BRAF group and the MSI high group that maybe got chemotherapy in the first line. So just a note on BRAF targeted agents. This was the Beacon trial, which tested encorafenib and cetuximab versus standard of care, which was slightly contentious. And what they showed was by targeting BRAF that there was a clinically meaningful and statistically significant improvement, again, in all of the endpoints. And in real life, actually, this combination is quite easy to give. It tends to be better tolerated than chemotherapy. There's some issues with skin toxicity that you can have, and some issues with headache, but actually it's well tolerated. And there's a phase 3, which we hope will report within the next year, which is testing it in combination with chemo in the first line. So I'm aware of the time, but just to make you aware of agents that are available in the third line. So we have regorafenib, which has been recently added to our armory in the third or fourth line. So this is an oral multikinase inhibitor, and it's been around for some time. I think the thing to stress is that it has quite modest activity. And we see the same in all of these drugs in this setting. We see very little in the way of progression-free survival. We don't see responses. So if you need a response in your patient, regorafenib is not the drug to give. You see quite a lot of side effects in terms of things like hand-foot syndrome, in particular, diarrhea, but actually mainly just lethargy. And so there is a flexible dosing. So you start at 80 milligrams, go up to 120, and then go to 160, rather than going in at the 160 dose. And this is indicated regardless of subtype. This is Lonsurf. So this is trifluridine and tipiracil. And there's not much between it in terms of the OS versus the PFS. So Chris, I'm going to put you on the spot again. Before, hopefully, my next slide showing the next clinical trial, if you see somebody coming in the third line, what kind of things would make you give Lonsurf versus regorafenib? That's quite a hard question.
Yeah, Lonsurf we've traditionally given to people who have had good responses to first and second line treatment. So I think people who've had poor responses, who've progressed quite rapidly through first and second line, are less likely or unlikely to do well with Lonsurf. Lonsurf is quite myelosuppressive as well. So people who've had issues with myelosuppression in the first and second line, it might not be the drug for them. Then regorafenib has come along more recently. As you say, it's not been shown to induce much in the way of a radiological response. So if you're looking for someone to have that needs that, then you might be slightly more likely, well, you're not that much more likely to have it with Lonsurf, but it's that's one of the considerations.
Yeah, well, interestingly, actually, I was speaking to so some of the doctors at Christie, and they regularly give GCSF along with Lonsurf. If neutropenia is the main issue, which it often is, because a lot of patients actually tolerate Lonsurf pretty well. I have to say it wasn't something that had really occurred to me to do before. Because to be honest, a lot of patients do progress quite early, but you do see odd people that go out to 6-9 months a year, and quite often you have to dose reduce because of neutropenia. So that was something that I hadn't thought of, but in particular with the sunlight data, which I don't appear to have a slide on here, this is the hot news of GI ASCO this year, and it's just been published in the New England Journal of Medicine, and that was just adding bevacizumab to Lonsurf, and that gave a further 3 months. So that was taking patients with a progression-free survival interval up to, I think it was 9 months off the top of my head, which is completely blown everything as a single agent out of the water. As I understand at the moment, the negotiations are going on with NHS England. So again, hopefully that's something that we will again have in our armory soon. And that's going to really revolutionise the third line setting in colorectal cancer. So that's very exciting. Fruquintinib is the other new kid on the block. So that's an oral inhibitor. So this is a oral inhibitor of VEGF 1, 2, and 3. And the FRESCO-2 study again had shown a meaningful improvement in overall survival. And this is in patients that were treated with regorafenib or Lonsurf. So this is us getting on to potentially fifth line treatment in colorectal cancer, which again, 5 years ago is just not something that we expected to see. HER2, very exciting. And again, this is something that I'm hoping that we're going to see in the next 6 months available in our armory. How we're going to test it, when we're going to test it is something that is ongoing. It's not yet on the test directory, but there's discussions about having it on the test directory. And this is on the background of the Mountaineer study. So there's a large story leading up to this, but certainly the tucatinib and trastuzumab seems to be in the lead in terms of the combination that seems most likely to go through. So remembering that there was zero response in the third line to regorafenib and Lonsurf, pretty much. There was nearly a 40% response rate in heavily pre-treated patients with HER2 amplification. So this is exciting in the third line, but hopefully more exciting with the trials in the first line. And again, this is something that was well tolerated. We sometimes see actionable rare protein fusions as well. If anyone has seen an NTRK fusion on the call, please make themselves known, because it's rare as hen's teeth, but it's interesting because if you can give them targeted treatment, they do quite well. So response rate, again, with heavily pretreated patients of 50%. So that's quite important. Now, I'm not going to go into detail on anti-EGFR re-challenge, but that is something that, again, is in the clinical trial setting at the moment. So these are RAS wild-type patients who have been treated initially with an anti-EGFR agent. They have a period off treatment, and then they're re-challenged again. This, again, is data from the Italians. And again, this is using drugs that we can easily access. And what they saw was, with re-challenge, they were seeing a response rate of 30%. Again, go back to regorafenib and Lonsurf of 0. So this, again, is an exciting area that hopefully we'll get into the mainstream as well. So to finish, we've got induction, we've got targeted treatment, we've got reintroductions, we've got moving from first to second to third line. It's an exciting area. I used to be able to do this talk in 15 minutes, and I think I'm over time at 35 minutes. So hopefully the ACP won't invite me back in 5 years, but I think it would take me 45 minutes to do this justice. So thank you. I'm very happy to take some questions. Or we can continue with Chris's talk.
Yeah, so there's no questions in the chat at the moment, but I had a couple of questions, if that's all right. So the first was, in terms of the chemotherapy, do you think we've optimized the chemotherapy? Is there any scope for improving that, or do you think that is now set, that we've got the best chemotherapy we can have, everything else is going to be about targeted advances, targeted treatments?
Well, I think there's always room for improvement. And I think in some ways that's what Lonsurf and S1 were looking to do. But I think the big difference in these patients will be further personalization at the start. So I think people will be increasingly divided into subgroups, and we'll be treating them slightly different with a chemotherapy backbone, most likely for the near future, because most of these agents can be easily added to chemotherapy. So I think the question will be more how to then put specific patients down the right track, and how to identify the people who really should be going for a potentially curative approach, because that pool of patients has been increasing, and whether things like ctDNA can help us identify those people who are best having surgery. I think there's going to be lots to come.
Okay, thanks for that. And the second thing, it was about the fruquintinib. Obviously, it's a pan-VEGF inhibitor. I'm presuming in those trials, lots of those patients had been pre-treated with bevacizumab, which obviously we don't have here. I don't know if you know how many were, and whether in the UK population where most people won't have had bevacizumab, whether that may be even more effective because they've not had any anti-VEGF treatment before.
Yeah. So that's an excellent question, Richard, for two reasons. So number one, when we talked about Lonsurf and bevacizumab in the Sunlight trial, which is something I think is going to be coming soon, there was approximately 30% of patients who hadn't had prior bevacizumab, and they were the patients that did the best. So the patients who had prior bevacizumab still benefited from Lonsurf, as they have done between going through first line and second line. So there's clinical trial data that supports continuation on bevacizumab on progression, which is, as you know, quite unusual in cancer treatment to continue a treatment despite progression. So it showed us that in the third line, continuing bevacizumab was reasonable. But why Sunlight's so exciting for the UK is because we'll have a large group of patients who aren't pre-treated. But indeed, with the fruquintinib trial, off the top of my head, the vast majority had previous bevacizumab. So I think we were talking about 3/4 of the patients had bevacizumab, and many of them had regorafenib as well, and even patients with prior regorafenib were within the subgroup analysis still benefited from fruquintinib.
Thanks, and I suppose one last question, if you don't mind. Do you think NICE will reassess bevacizumab at any point in the future, or do you think that's something that we'll just never have access to?
Yeah, it's one of the big oddities about NICE. It's never made the cost effectiveness hurdle, and I suppose a lot of us were waiting for the biosimilars to come along when bevacizumab went off patent, and that's kind of not hugely happened. So it is something that remains a bit of a mystery to me. I'm not sure if anyone on the call knows any more about it than I do, but certainly going along with the Lonsurf bevacizumab has made the whole reevaluation come up again. But it's down to costing. It's down to what price they're prepared to give it at. But certainly we are outlying within most of Europe and the States in terms of bevacizumab use. On the other hand, you can quite easily say it's not shown an overall survival advantage in the first line trials. So I can see both sides, but I don't see it happening in the near future.
Okay, yeah, I can see that. And so, in your opinion, if there was no limitation about funding, do you think you would give bevacizumab in first line to patients? Is that yeah,
unless there was a reason not to. I mean, as I said, with the TRIBE study, it was with bevacizumab. So all of the evidence for the triplet chemotherapy is in combination with bevacizumab. It's a drug that people are quite used to using in gynecological cancers, lots of different indications. So I don't know.
Yeah,
I've never been asked to contribute to that committee. Yes, but I can say that it is being evaluated at NICE with Lonsurf now. I do know that for a fact. So, I mean, this is going to be quite often you're having a third line conversation with patients, and you're kind of saying, well, we do have these things available, but you have to temper that very much with you have to meet you have to manage their expectations. We're not going to see great responses. We're not going to be able to improve somebody's symptoms hugely with Lonsurf in the way you could do with first and second line. So fingers crossed, because if the data pans out in the real world, I think it's very exciting.
It's always a question, isn't it? Does the real world population match your trial population? But that's another question for another day. Well, thanks for that very much. Thanks very much, Jenny, for that excellent presentation. I don't think we've got any more questions on the chat, so if we're happy, we'll move on to Chris. So Chris Williams is a medical oncology registrar here in Leeds. He graduated from Edinburgh in 2011 and completed his training in Leeds, London, and Sydney. He's currently a CR UK Clinical Trials Fellow at the Leeds Trials Unit, and he's the trial physician for the Aerial trial and the Foxtrot platform. His research interests include prognostic and predictive biomarkers with particular relevance in the neoadjuvant setting, and he's going to talk to us today about localized colon cancer. So I'm really looking forward to this, Chris. So I'll hand over to you when you're ready.
Great, thank you very much, Richard, and thanks to the ACP for inviting me along today. I'm very pleased to be speaking here alongside Jenny. These are my disclosures. As I say, we're going to talk about localized colon cancer here, specifically colon. I will mention rectal a couple of times, but there won't be much focus on rectal in this talk. I'll talk about current practice briefly, and then we'll move on to current and emerging prognostic and predictive biomarkers, both immune biomarkers and the burgeoning world of ctDNA that is coming. And then I'll spend some time talking about neoadjuvant treatment strategies, which is obviously us in Leeds are a particular area of interest. The completed trials have been performed in this area, and looking at more novel trials moving forwards. So here's the stage 3 disease algorithm from the most recent ESMO guidelines from 2020. So adjuvant chemotherapy is quite well established in stage 3 disease, and less controversy here than there is in stage 2 setting, which I'll come on to in a second. There's an absolute reduction in risk of death of about 10 to 15% with single agent fluoropyrimidine chemotherapy. And from the MOSAIC trial, we know you get an extra about 4 to 5% reduction with oxaliplatin. Mismatch repair status is very relevant in considerations for adjuvant treatment, but it's less relevant in stage 3 disease than it is in stage 2. So the reason behind that, we see that mismatch repair deficient colon cancer is most prevalent in early stage disease, stage 1 and 2, and becomes less prevalent as you go into the higher stages. And while it's a good prognostic marker in early stage disease and indicates a lower risk of metastasis, once it has metastasized, then it's a poor prognostic marker. And stage 3 is sort of the intersection there between that curve. So both patients with MSS, microsatellite stable, and MSI disease are offered treatment usually in stage 3 disease. Age used to be a factor in guidelines for consideration of giving or not giving oxaliplatin. In the MOSAIC trial, then the over 70s in the MOSAIC trial didn't get benefit from oxaliplatin. And you'll see on the flow chart there from ESMO guidelines that that's not included in the current guidelines. And Jenny, I don't know if is that something in your practice that influences you at all, age and oxaliplatin?
It's a topic close to my heart. I think what we need to think about is that there's been no trial looking at treatment of older patients with colon cancer, which is important because the median age is 71. And you have to think about who was recruited into these trials. Are they representative of the whole population? They're more likely to have had treatment stopped early, and we know early treatment discontinuation is associated with poorer outcomes. And I think going back to mismatch repair, Chris, I think the other thing that's quite clear is that these are a different population as well, and these are overrepresented in the older population. So I don't use 70 or under. I use fitness, and of course fitness and age often go hand in hand, but certainly if I had a very fit 75-year-old who was excellent, I wouldn't change my practice based upon that age meta-analysis.
Yeah, so yeah, I think that's reflected, isn't it, with the ESMO guidelines as they are now and practice generally. And really that stage 3 treatment algorithm has stayed very much the same since the MOSAIC trial in the early 2000s, apart from the addition of the IDEA collaboration data, which we've had for a few years now, which was a series of trials conducted across a number of countries, including the Scott trial in the UK, that was comparing 3 versus 6 months of treatment. Whilst the 3 months of treatment didn't strictly reach non-inferiority, it did certainly show in some defined subgroups, and it did look, you definitely get most of the benefit from the chemotherapy in the first 3 months, and that's been used to define high risk and low risk subgroups of stage 3, the PT1 to 3s and N1s as low risk, and the T4s and N2s as high risk. But that's the level of evidence there to define whether you should get 3 or 6 months of treatment is classed as level 5. So it's expert opinion here because we're looking into non-predefined subgroups in the IDEA collaboration. One thing that did seem to come through very clearly was that whilst it was quite reasonable to give Capox for 3 months, then Folfox, there was less strong evidence that you could reduce that to 3 months, certainly in the high risk subgroups. And Jenny, how do you find that the IDEA collaboration has influenced your practice? Do you use these high risk and low risk subgroups, or do you have more of a err on the giving 3 months unless there's a good reason not to? Do you stop the oxaliplatin? I have three questions.
So always stop the oxaliplatin. There's there's a paper in JCO that came out earlier this year by Claire Gallois, which showed that stopping the oxaliplatin at 3 months versus 6 months had no impact on disease-free survival. So the clear message is the question is to continue 5FU or not, but do stop the oxaliplatin at 3 months. As you say, Capox for 3 months, I feel pretty secure with. I think the data's pretty clear. You're looking at 1 to 2% differences for infusional 5FU. I would be tempted to give to finish the 6 months, depending on tolerance. But I don't use this high risk versus low risk probably as much as the guidelines would suggest.
Yeah, and that reflects, it's just this is low level evidence that they've used to construct this that guidelines there. So moving on to stage 2, where it's an area that's a bit more controversial perhaps than stage 3. So here with adjuvant chemotherapy, there's an absolute reduction in risk of death of 3 to 5% with single agent fluoropyrimidine. And in the MOSAIC trial, there was no benefit from the addition of oxaliplatin to the fluoropyrimidine in stage 2 disease. So generally speaking, it's single agent treatment that is given. There's a greater role, as I've said, for mismatch repair status, and so patients with low risk or intermediate risk, microsatellite unstable, deficient mismatch repair disease, the guidelines suggest not to give any adjuvant treatment. And you can see on the guidelines there are multiple clinicopathological factors that you can consider that indicate poor prognosis, a higher risk of recurrence. And these are used to define these low, intermediate and high risk groups in the ESMO guidelines to help decision making regarding adjuvant treatment, with higher risk disease recommending to give to give the chemotherapy. And you can see as well in this guideline that they've added in the oxaliplatin to the very high risk disease, and that's contrary to what those findings were from the MOSAIC trial, but consistent with observations that patients with T4 disease have a risk of recurrence that's equivalent or sometimes exceeding patients with stage 3 disease. And so we're really looking at these prognostic markers to guide us. And the reason why we're looking at prognostic biomarkers, obviously patients with recurrence risk are the ones who you want to mitigate that risk, but also we don't have any predictive biomarkers really available to us that predict exactly who benefits from chemotherapy. There's no efficacy biomarkers there, and so that's what I'm coming on to look at in this slide here. We've got this Venn diagram that's also from the ESMO guidelines that shows you what your considerations are when you're thinking about the indication for adjuvant chemotherapy. There's the patient factors, the risk of toxicity. So Jenny's just spoken about how we are not great at measuring frailty, but this is an evolving field where people are getting, there's growing evidence base for how we can really more objectively define who is frail and who isn't, and how that might feed into trials where we can specifically say who would be at too much risk to consider chemotherapy and who would be fine to consider it. And we do have some toxicity biomarkers now, and DPD is the one that we use very frequently to identify people at high risk of 5FU toxicity. Age, as we've discussed, is becoming less used, although previously has been used more objectively in the past. High risk of recurrence, as we've said, there are those clinical pathological features that you can look out for on your path report and when you're assessing the patient. And they're quite well established. We've got a lot of prognostic biomarkers, but who is expected to benefit from adjuvant chemotherapy? Yes, that overlaps a little bit with risk of recurrence, but do we know when chemotherapy is going to work? Not really. We don't have a great predictive biomarkers for that. So what's the work that's been done in this field? there's been a strong focus for a long time on immune biomarkers, and it's going back to quite a fair time, sort of mid-80s, where some pathologist-assessed scoring systems were defined looking at inflammatory cells in the invasive margin of the tumor on an H&E slide, and just giving it a score based on a pathologist-assessed criteria by eye down the microscope. And there's a couple, the Clintrop-Mackinnon and the YAS scores, that are quite well validated, and then there's a sort of profusion of tumor infiltrating lymphocyte scores, both in the invasive margin and in the core of the tumor, that have been done over the years. And really all of them have shown that the higher the density of tumor infiltrating lymphocytes wherever you look in the tumor area, then the better the prognosis. People have tried to nail down exactly what kind of lymphocytes or immune cells are benefiting here, and there's really great systematic review and meta-analysis by the Glasgow group, Alexander et al., showing all of the evidence base here. There's consistent prognostic effect, positive prognostic effect for T cells, all T cells, cytotoxic T cells, T helper cells, effector memory T cells, B cells, natural killer cells. Regulatory T cell transcription factor, FOXP3, has given inconsistent results, and also the macrophage markers give us inconsistent results, and that reflects this theory that we have these good macrophages, bad macrophages, and we need to tease that out a bit more. What this possibly all means, though, is there's so many strong positive prognostic biomarkers in the immune contexture, then possibly really what we do need is just a coordinated immune response. And so just combining information from more than one biomarker, is that helpful? And the Immunoscore is possibly the most famous example of this, and that's a combination of CD3 and CD8. That's all T cells and just the cytotoxic T cells, looking at the core of the tumor and at the invasive margin, and giving a combined score for those two markers in two regions, so 4 scores together. It's using AI-based quantification and scored against a reference population, and that showed a consistent positive prognostic effect across all stages of colorectal cancer. And what was really important is that that prognostic effect was independent of mismatch repair status. So we know that deficient mismatch repair tumors have a higher, generally a higher level of tumor infiltrating immune cells. But the CD3 and CD8 score was independently prognostic of that, prognostic independently of that, I should say. And it was also prognostic independent of the traditional clinical pathological risk features that we went through on the early slides in the guidelines, including the TNM staging itself. But importantly, so why are we not using this very strong prognostic marker in routine practice at the moment, apart from it's quite an expensive thing to run? It didn't have any proven predictive effects, and in fact, in the looking back at the Quasar trial, which is one of the earlier trials of 5FU adjuvant chemotherapy versus observation in mainly a stage 2 population, then we didn't see any predictive effect there from this marker. So it may well be that that this remains sort of in the research space. Interestingly, the Atezo Tribe trial that we just mentioned briefly in the metastatic talk, which was looking at atezolizumab, the anti-PD-L1 drug, in the advanced disease setting, but in proficient mismatch repair tumors in combination with chemotherapy, then a version of the Immunoscore biomarker looking at the CD8 cells and their co-localization with PD-L1 did show some positive predictive effect in pMMR tumors, which is very interesting to see. So there may be some that may be coming along soon as well. So ctDNA is a very hot topic, of course, at the moment. It's a very complex area. There's multiple technologies. There's tumor-informed approaches, tumor-agnostic approaches. Consistently, there's a strong prognostic effect in early-stage disease from the sheer quantity of circulating tumor DNA. And is it perhaps more than just one of the other prognostic biomarkers showing high risk of recurrence? Is it really a direct indicator of minimal residual disease? That's the question. Certainly the most exciting trial that's been published in this area is in colorectal cancer is the dynamic trial, and that was looking at stage 2 colorectal cancer, and it was randomizing between a ctDNA guided approach to management versus standard of care. And so the patients who were randomized to the CT guided approach, if they had positive ctDNA, then they did get chemotherapy, and if they had negative ctDNA, then they didn't, versus if you're in the standard of care group, your ctDNA levels were recorded, but you just proceeded with treatment as you ordinarily would based on clinical pathological risk features. And in the study, it was a positive study saying that by predefined criteria, the ctDNA guided approach was non-inferior with regards to 2-year recurrence-free survival. And additionally, it resulted in the lesser use of chemotherapy. Of only 15% of patients in the ctDNA guided group got chemotherapy, whereas almost double that number got, or double that proportion got chemotherapy in the standard management group. We're not yet using this in clinical practice, so perhaps it hasn't been practice changing. Is that something you'd agree with, Jenny? And what would you think about with in terms of what we need to show this is practice changing?
Yeah, I mean, there's one group that I know you're not digging into all the details of this, but the one group that really jumped out was the T4 group. So within the T4 group, who were ctDNA negative, they had a higher risk of relapse than the ctDNA positive patients who didn't have treatment. So actually, T4, the concern, I think, is that in particular, the T4 tumours are not shedding ctDNA. And again, that's something that you see with them in the advanced setting with peritoneal disease, is that they're less likely to shed ctDNA. So I think within the low risk group, it's really exciting, and we don't want to give people chemotherapy who don't need it. But I think with the T4s, there's a lot of concern. There's a lot. I'm very supportive of TRACK. I'm very supportive of the studies that are ongoing in terms of getting the assay right. There's a lot of work to do, and I think there would need to be a confirmatory study to dynamic to really change people's practice. Is what I understand the main feeling is.
Yeah, great. And you mentioned TRACK there, and TRACK-C, as you say, is being run by in the stage 3 disease patients, randomizing between a ctDNA guided approach to management versus standard of care. A similar primary endpoint, this time 3-year disease-free survival. And there's also an option to escalate treatment if the ctDNA is initially negative but becomes positive at a 3-month time point. So that would be an interesting thing to see if we can, if that makes an impact there. In the Circulate trials, these are going on in a number of different countries, and here they're looking at slightly different trial design, looking for a predictive effect of ctDNA. In the French group, we've got Prodige 70, and in Germany, the AIO KRK0217, very catchily entitled. And they're looking again at stage 2 disease, similar to dynamic. Here, they're randomizing ctDNA positive patients. So they're randomizing once you know the ctDNA result rather than beforehand. And they're randomizing 2-to-1 between adjuvant chemotherapy and observation. In the US, similar study design with randomization after knowledge of the ctDNA result. Here you have 2 options, ctDNA negative, it's chemo versus observation, and ctDNA positive, it's everyone gets chemotherapy, it's whether you get oxaliplatin and fluoropyrimidine or FOLFOXIRI. Here, the Circulate US trial is taking into account that T4 subgroup, that risky T4 subgroup that we worry about not shedding, that Jenny mentioned, and that's being accounted for in the trial design. And then in Japan, perhaps the most ambitious of these studies, if you're ctDNA positive, you'll be randomized between Lonsurf and placebo. So again, that will be an interesting one to see the results of. These are all ongoing trials. So ctDNA is rapidly changing, and I'm sure that we'll be using that technology at some point in the near future in our clinics in some form, and we're just waiting to see how. So what about neoadjuvant strategies? These neoadjuvant treatment strategies have got some well-established advantages and potential disadvantages or concerns that people might have. What are the potential advantages? Well, we know that there's a delay between surgery, or between diagnosis rather, and then once you've recovered from surgery, proceeding with adjuvant chemotherapy. And if the purpose of adjuvant chemotherapy is to treat micrometastatic disease, then surely it would be better to treat that earlier rather than later down the line. There's been other cancer types where, apart from colorectal cancer, colon cancer rather, that have had positive neoadjuvant experiences. And there is this potential, this research potential for a window of opportunity study, and I'll come on to that in a bit, providing pre and post-treatment samples for translational research as well. The concerns clearly are that patients might not proceed to their surgery if they either progress during the neoadjuvant treatment period, or if they develop severe toxicity that means that they can't safely proceed to surgery. And there is also the legitimate concern, will giving a heavy-duty systemic drug in the preoperative period put you at risk of perioperative complications? And also the big one is that throughout the history of colon cancer, we have always based our decision-making in the adjuvant setting on the pathological staging after operation. And can we use radiological staging as a proxy for that? Does it need to be a proxy for that? That's another question. So there are a number of trials that have completed in this setting now. I've added the NeoCol trial to this list, which was presented at ASCO. And of course, from our group between Leeds and Birmingham, then the Foxtrot trial, which the full results were published earlier this year. So Foxtrot 1 was a neoadjuvant trial, moving 6 weeks of your adjuvant chemotherapy into the neoadjuvant treatment period if you had radiologically staged T3 to 4 and 0 to 2 locally advanced colon cancer. And the headline results from that was that there was a reduction in 2-year recurrence, improved 3-year disease-free survival. There were fewer positive margin or R2 resections, and fewer post-operative, perioperative complications, which was very pleasing to see, clearly very reassuring. And there was histological tumor regression, and that was an important finding that I'll come on to in a second in terms of what implications that has for future research. So just summarizing the 4 trials in this area, the Foxtrot trial was a bit larger than the optical trial that was conducted in China, and much larger than the French trial and the Danish trial down the bottom. They had similar designs, just with slightly different durations of neoadjuvant treatment and different criteria for what you do in the post-operative period. And in terms of what was found, well, downstaging was consistent across all trials, and treatment did effectively downstage tumors. Consistently, it was found that, although not in the smaller Prodige trial, that with neoadjuvant chemotherapy, you got a higher rate of R0 resections. But it wasn't consistent that there was an improvement in longer-term survival outcomes across all of the studies. And Jenny, I think this is an area where obviously you spend a lot of time thinking. So what's your takeaway from this kind of slide where we're looking at the difference between these different neoadjuvant trials?
Yeah, no, it's really complex, because is they're all at different stages of reporting. So only Foxtrot and Prodigy have actually finished reporting. Neocall, we got very little data about, and that was a completely different study where they de-escalated treatment in the adjuvant setting. And then they looked for a 10% improvement in survival whilst de-escalating treatment. So the one thing I would say is when you're looking at trials, particularly adjuvant or neoadjuvant trials, is try and understand what effect size they were looking for between the trials. How much of a benefit are you expecting to see? If you're expecting to see a 10% benefit, and that will of course give you a 300 patient trial, because your power is very high. So you need this 300 patients. Then for an adjuvant study, you'd be expecting close to 1,000 patients. So I'd be wary. We're not going to go into a lecture on statistics, but in Foxtrot, we were looking for approximately a 5% improvement by moving treatment. And when you think about adding oxaliplatin, only added a 5% improvement in disease-free survival. You have to be a wee bit realistic. In optical, they looked for 8% improvement, and hence why their numbers were lower than Foxtrot. So it's a complete minefield. And sometimes people will just look at a p-value, and actually a p-value doesn't tell you a huge amount. Overall survival, none of these trials are powered to look at overall survival. So meta-analyses, it will be what is needed. So what we're excited about is trying to link up with the optical team and combine the data sets, because at that point we'll have enough data to look at overall survival, which of course has to be the most important endpoint.
Absolutely. So, and then so what is consistent, I guess, across the trials in terms of positive findings is that the patient pathway was deliverable. There wasn't an increase in perioperative complications in many of the trials. There was a reduction in perioperative trials, and there was significant downstaging as well. A key finding was that there was lesser benefit from neoadjuvant chemotherapy in tumours with deficient mismatch repair or microsatellite unstable tumours. And so in Foxtrot, for example, there wasn't, you didn't get a disbenefit from neoadjuvant chemotherapy if you had a dMMR tumour, but you didn't get benefit. I mentioned how pathological response could be assessed in the resected tumour, and we've got validated regression grading scores for doing that with chemotherapy. And you can see what that really highlighted in Foxtrot is how closely pathological response equates to recurrence-free survival. And that's a really useful finding in terms of using this as a surrogate endpoint in future trials. It's been an observation that's been made across a number of neoadjuvant trials. And why it's particularly important is because this is a very quick readout you get from the trial. And so it speeds up the pace of research if you're not waiting months and years down the line for evidence of recurrence. Instead, you're just looking very quickly after a few weeks of treatment for your endpoint. And that's what window of opportunity trials are taking advantage of, and NICHE is a great example of this. So window of opportunity trials are saying, look, we accept that between the time of diagnosis and the point of surgery, there is this gap of a few weeks normally. The NICHE trial was a Dutch trial. They calculated that the average wait time between endoscopy and surgery was 6 weeks. They said, can we give some treatment in this period? And they were testing immunotherapy with just 2 doses of nivolumab, 3 milligrams per kilogram, and 1 dose of low dose ipilimumab, and before surgery, and looking at for any benefit in terms of pathological response and then longer term outcomes as well. And this is the readout from the NICHE 2 trial. And here you can see that there, with immunotherapy and deficient mismatch repair tumours, then there was a huge overwhelming response with 95% of patients exhibiting a major pathological response, and 67% of patients after just 6 weeks of immunotherapy having a complete pathological response to treatment. So this is a really excellent example of a window of opportunity trial. So what other markers what other ways can we perhaps personalize neoadjuvant therapy? We've got this, Jenny was presenting a similar diagram to this that shows you just the different biomarkers that we have in routine use in colorectal cancer at the moment, and then there's others coming along all the time. How can we make a more personalized approach to neoadjuvant therapy? And that's really where the Foxtrot platform is now concentrating. And there's other platforms across Europe as well. A unicorn in Italy. There's a German platform, and also in France, the NEO platform, who we're collaborating with on the HER2 arm of Foxtrot. So there's different targeted approaches to treatment that are taking advantages of this window of opportunity to test something novel whilst not depriving someone of potential adjuvant therapy after surgery. One thing that was exciting from niche that I didn't mention in the previous slide. So the previous slide was showing niche 2 results, and this is a slide from niche 1, where patients with proficient mismatch repair tumors were included. The majority still had deficient mismatch repair tumors, and they're shown in red, and the proficient ones are shown in green. Clearly, the tumors with proficient mismatch repair didn't get as much benefit as those with deficient mismatch repair. But in the advanced disease setting, then we haven't had very much of a signal at all that there are patients with proficient mismatch repair tumors who benefit from immunotherapy, apart from that Atezo tribe data that I mentioned briefly earlier on. And so this is really exciting that we're seeing actually 30% of just approaching 30, or 27% to be exact, of patients with proficient mismatch repair tumors achieved a major pathological response. 2 of them achieved a complete pathological response with just 6 weeks of immunotherapy. And so it's a major opportunity here to now say, well, who are these patients? How can we identify them? And how can we provide effective treatment with immunotherapy to them? Can we perhaps expand the pool of patients? And why a neoadjuvant setting is really presents such a great opportunity to do that is because you get this pre-treatment and post-treatment sampling and a quick readout from pathological response that lets you move that field forward very quickly. And what we're really hoping for one day is perhaps a non-operative approach to management, and that's starting to be realized now. And this is a slide from the Sursek paper in the New England Journal presented at ASCO. And this was in the rectal cancer setting, locally advanced rectal cancer, so a little departure from colon cancer. This was looking specifically at patients with deficient mismatch repair tumors and testing neoadjuvant, I put it in inverted commas, dostarlimab, an anti-PD-1 agent from GSK. And there was the option in this study for a non-operative approach to management if you had a complete clinical response. And in all 23 patients who have so far completed the therapeutic course, all of those patients have had a complete clinical response. So not one of them has undergone operative management. And the Azure-1 registration trial is soon to open. So that will really see if we can get this embedded in the standard of care. It's an exciting trial. Clearly, these patients are avoiding radiotherapy. They're avoiding surgery, which can be more intense and more and leave you with a greater symptom burden in the post-operative setting for rectal cancer than it often does in colon cancer. Why it's really the limitation here, I guess, is that the deficient mismatch repair tumors are quite rare in the rectum in comparison with other parts of the colon, particularly the colorectum, and particularly the right side of the colon where they're more common. And so this is not going to be a large number of patients that are undergoing this form of treatment. The majority of patients with rectal cancer won't be going down this line. what we need to bear in mind in terms of how translatable this is to the colon cancer setting is that we're very much able to monitor very closely patients' response, both with proctoscopy, but also with digital rectal examination, and also MRI, which isn't possible in the colon. So those factors need to be thought about if we're trying to translate this into the colon cancer setting. So to summarize quickly then, before we finish, then care for locally advanced colon cancer changed little over recent decades. We just added in oxaliplatin and not much else changed. But now, as I hope I've shown you, it's evolving very fast, and we can expect to see a lot of changes on the horizon coming into clinic. Immune biomarkers, ctDNA, helping improve patient selection, and neoadjuvant chemotherapy is established as a new therapeutic option. And window of opportunity trials are going to hopefully help us improve personalization of care. And then finally, non-operative approaches to management might well be something that we see coming to the clinic in the future. So thank you very much. I've just put a little reminder that Leeds is hosting the ACP weekend in November, and I hope to see everyone there.
Thanks, Chris, and thanks for that plug at the end. There will be more details coming out about that. Don't worry about the ACP weekend in the near future. There was one question through the chat, which Professor Seligman kindly has already answered. I don't know if there are any other questions from the chat. The one thing I'd ask is, in your experience, the two of you, how have you found discussing with the MDT, particularly the surgeons, about having neoadjuvant treatment when it's not something that's been previously done? How easy has it been to convince them of the benefit of this treatment?
Yeah, there's a tricky conversation. I think certainly an MDT approach to neoadjuvant care is really what you need. You need to get everyone involved from the outset. You need to set your stall out and show them why you think it's going to be a good idea. Show them, I think what surgeons care about most is their surgical outcomes. The last thing they want to be doing is looking after a poorly patient who's not recovering after their operation, and it's not the fault of their surgery, it's the fault of some drug that the oncologist gave before the surgery. And so that data from Foxtrot and also from those other neoadjuvant trials is surely very reassuring for people that in fact you get improved surgical outcomes. A lot of time needs to be spent and has been spent in the Foxtrot group in terms of showing just how you can stratify patients for risk, particularly of things like obstruction. Your worry is that someone is going to obstruct in the neoadjuvant period, and that can make a bad situation very much worse. So strategies for identifying that and for mitigating that, either with defunctioning ahead of the operation or with stenting, is becoming increasingly more common, is an important thing.
Yeah, agreed. Just takes conversation, and actually I found a lot of surgeons are very pro this. They're very excited about the IO, and quite often you have to just bring people with you. It took 20 years to establish neoadjuvant pathways for rectal cancer with radiotherapy. It's not something that you can expect the MDT to just change everything overnight. It does take a while. In our practice, there was some surgeons that were up front, they were all for it, but actually once we started treating more people, they got more confidence in the whole structure, and the radiologist is the person that you really need, because they're the people that identify your patients. So it's, as Chris has very rightly said, it's a team sport.
Brilliant. Thanks, and thanks both for your talks and your inputs. I think there's no further questions, and I think we're just approaching 7:30, so I think if that's okay with you, we'll wrap things up. But I think it's been really interesting, lots of really interesting developments, and yeah, we're sure to be inviting you back in not 5 years' time, but sooner than 5 years' time, when hopefully we'll have even more treatment options.
It's a busy time in colorectal. It's a good field to be in for anyone who's still pluripotent.